Welcome to the deep dive. We're here to take essential info and, well, make it stick for you.
That's the plan.
Today, we are really getting into Patau syndrome, which you'll also know as trisomy 13.
hmm
We know you're looking for that clear, high-yield rundown, maybe for revision, and that's exactly what we aim to provide.
Absolutely. We'll hit the key stuff.
Yeah, we'll break down what it is, the causes, the features you need to spot, diagnosis, management, and hopefully throw in some memory aids, too.
That sounds good.
So let's just jump straight in. What exactly are we talking about when we say Patau syndrome?
Okay, right. So Patau syndrome, or trisomy 13, fundamentally it's a genetic disorder. It happens because an individual has an extra copy of chromosome 13 in their cells. Instead of the usual 2 copies, they have 3.
3 copies, okay.
And this extra genetic material, it really causes widespread problems. We see significant developmental abnormalities, malformations in multiple organs.
And I gather it's quite serious.
Extremely serious, yes. The severity of these congenital issues, well, it often leads to a very high mortality rate, sadly, and significant impairment for those who survive longer.
So it's all down to that extra chromosome 13. You mentioned how it happens. Are there different ways someone ends up with that extra copy?
Yes, that's a good point. The most common way is what's called freestanding trisomy 13. Basically, every single cell in the body has that full extra chromosome 13, simple duplication.
Right.
In every cell.
Exactly. But it's not the only way. We also see cases involving what are called unbalanced chromosome translocations.
Translocations. Okay, how does that work?
So specifically, a Robertsonian translocation is often involved. You can sort of picture the extra chromosome 13 material attaching itself onto another chromosome. So the person might not have a whole extra free chromosome 13, but they have extra chromosome 13 material stuck somewhere else.
So it's like it's hitching a ride on another chromosome.
That's a great way to put it, yeah.
Mm.
It means they still end up with too much genetic information from chromosome 13, functionally speaking.
And this matters for inheritance, doesn't it? If a parent carries a balanced translocation.
Precisely. Someone can carry a balanced translocation where the right amount of genetic material is present, just rearranged and be completely healthy. But they have a higher risk of producing sperm, or eggs, that lead to an unbalanced arrangement in their child, like trisomy 13.
Okay, that's clear. And there's another term you mentioned, mosaicism.
Ah, yes, mosaicism. That's different again. In mosaic Patau syndrome, not all the cells in the body have the extra chromosome 13.
So a mix.
Exactly. Some cells have the normal 46 chromosomes and others have the 47 with trisomy 13.
And what does that mean for the person?
Well, it often means the effects can be quite variable. Generally, mosaic cases tend to be milder than full trisomy 13. The severity really depends on the proportion of cells with the extra chromosome and which tissues are most affected.
So you might see a much wider range of outcomes.
Definitely. In some cases, where there's a high number of normal cells, the presentation could be much less severe. Maybe only subtle physical signs, which could even lead to a later diagnosis, or sometimes potentially missed altogether, although that's less common given the typical features.
Okay, that's a really helpful breakdown of the what. Let's move to the why. What's the actual cause, the etiology, behind getting this extra chromosome in the first place?
So the fundamental cause, like we said, is having 3 copies of chromosome 13. But why that happens? It typically arises from a random error during meiosis.
Meiosis, the process that makes sperm and egg cells.
Exactly. It's usually a mistake in cell division, called nondisjunction, where the chromosome pairs fail to separate properly when the sperm or egg is being formed.
So is this something parents pass down? Is it generally inherited?
In the vast majority of cases, no, it's not inherited. It's usually just a spontaneous random event that occurs during the formation of that specific reproductive cell. So it's typically not something passed down from the parent's own genetics, unless we're talking about that translocation scenario we discussed earlier.
Right, the translocation is the exception there. Okay, so if it's often random, are there any known risk factors? Anything that makes this random error slightly more likely?
Yes, there are a couple of things we know increase the risk slightly. One of the main ones is advanced maternal age.
Okay, that comes up with other trisomies too, doesn't it?
It does. Similar to conditions like Down's syndrome, the chance of having a baby with Patau syndrome does increase as the mother gets older.
Any other factors?
Yes, also, if a couple has previously had a child affected by Patau syndrome, or indeed another chromosomal condition, their risk for subsequent pregnancies is slightly increased compared to the general population.
You mentioned maternal age. Is the effect as strong as it is for, say, Down syndrome?
That's a good question. While there is an observed link between advanced maternal age and Patau syndrome, The effect is generally thought to be less pronounced than what we see with trisomy 21, Down syndrome, or even trisomy 18, Edwards syndrome.
Interesting distinction. Okay, so we've got the definition, the cause, and the risk factors. Let's dig into the how. How does this extra chromosome 13 actually cause all the problems, the pathophysiology?
Right. So essentially having that entire extra chromosome 13, it just completely disrupts the normal, very finely tuned process of development.
How so?
Well, you've got 3 copies of all the genes on that chromosome instead of 2. This leads to an overexpression of certain proteins and gene products. Think of it like a recipe. If you just triple one specific ingredient, the whole dish is going to be thrown off balance.
Okay, yeah.
It's similar here. That imbalance in gene activity interferes with critical developmental pathways right from early embryonic development. And the result is these widespread structural problems, the functional abnormalities, the organ malformations that characterize Patau syndrome.
That recipe analogy works well. It disrupts the whole system. So when a clinician sees a baby with these kinds of complex issues, what else might be on their mind? What's in the differential diagnosis?
Absolutely critical question. You need to consider other conditions. Trisomy 18, Edwards syndrome is a key one. It shares some features, although it has its own distinct pattern.
Okay.
Trisomy 21, Down syndrome, less likely to be confused clinically, usually, but it's another common trisomy. Then there's Smith-Magenis syndrome that's caused by a deletion on chromosome 17, but can have some overlapping features sometimes.
Any others?
Yes, interestingly, there's something called pseudotrisomy 13. These are babies who have many features suggesting trisomy 13, but when you test their chromosomes, they're actually normal, karyotypically.
Wow, okay.
So that's important. And then more broadly, you have to consider other complex chromosomal abnormalities and just certain congenital malformation syndromes in general that might present with multiple issues. So yeah, careful examination plus genetic testing is really key to nail the diagnosis.
It really highlights the importance of that genetic confirmation. Okay, let's talk numbers. How common actually is Patau syndrome? What's the epidemiology look like?
Well, looking at the UK, the prevalence is estimated at somewhere around 1 in 10,000 to perhaps 1 in 16,000 live births.
Okay.
If you look at global figures for trisomy 13 more broadly, estimates range a bit wider, maybe 1 in 5,000 up to 1 in 29,000 live births. There's variability in reporting and diagnosis.
And where does it rank compared to other similar conditions?
It's the 3rd most common autosomal trisomy we see in newborns. So it comes after trisomy 21, Down syndrome, which is the most common, and trisomy 18, Edwards syndrome.
Right. So serious, but less frequent than Downs or Edwards. Now, let's get into the clinical picture. What does Patau syndrome typically look like? What are the key clinical features you'd expect to see?
Okay, the clinical features are often quite striking and involve multiple systems. A really central feature is severe intellectual disability. That's almost universal. Then you have the congenital malformations. Very common ones include cleft lip or cleft palate, or sometimes both. Congenital heart defects are also extremely common, seen in a large majority of cases.
What about limbs?
Yes, limb abnormalities are frequent. And a really classic finding one to remember is polydactyly.
Polydactyly. Extra fingers or toes?
Exactly. Extra fingers or toes.
That feels like one for a mnemonic. How about Patau has plenty of digits?
Oh, I like that. Patau has plenty of digits. Perfect. Yes, that's a great way to remember polydactyly.
Huh. Okay, good. What else?
Other things. You can get scalp defects, like missing skin on the scalp, called cutisoplasia. Neurologically, a very severe and characteristic finding is holoprosencephaly.
Holoprosencephaly. What is that?
That's where the forebrain fails to divide properly into 2 hemispheres during development. It's a major structural brain defect.
And that would link to the intellectual disability.
Absolutely. It's often associated with midline facial defects, too, like closely faced eyes or even just a single eye structure in severe cases, and contributes significantly to the severe learning disability. Neural tube defects can also occur.
It's such a wide range of systems affected. What about the head and face more generally?
Yes, other craniofacial features are common. Microcephaly, meaning a small head size, is typical. Ear malformations are also frequent. And as I mentioned, those scalp defects can be present. And just to reiterate the heart, various types of congenital heart defects are very common indeed.
And it doesn't stop there, does it? What about gut and urinary systems, GI and GU issues?
Correct. Gastrointestinal problems like omphalocele, where some abdominal organs protrude outside the belly button in a sac, can occur. Hernias are also seen. In the urogenital system, you might find polycystic kidneys or micropenis in males, or coloral hypertrophy in females.
Okay. And finally, you mentioned hands and feet earlier with polydactyly. Any other specific features there?
Yes, besides the extra digits, you often see small, sort of overly curved, hyperconvex fingernails and toenails. And another characteristic feature is rocker bottom feet.
Rocker bottom feet.
Yeah, the sole of the foot is rounded, convex, kind of like the bottom of a rocking chair, instead of having a normal arch.
Got it.
And it's really the cumulative effect of all these severe problems across so many different body systems. That's why, sadly, Patau syndrome often leads to stillbirth or death very early in the neonatal period.
It certainly paints a picture of a very complex and severe condition. So moving on to confirmation. How do doctors definitively diagnose Patau syndrome? What are the key investigations?
The absolute cornerstone for confirming the diagnosis is chromosomal analysis. You need to look at the chromosomes.
That done?
Traditionally, it's done using karyotyping, where they literally take a picture of the chromosomes and arrange them to see if there's an extra chromosome 13. More recently, chromosomal microarray analysis is often used.
Microarray, what's the advantage there?
It's a more high-resolution technique. It can detect the extra chromosome 13, but also much smaller deletions or duplications elsewhere in the genome that karyotyping might miss. It gives a more detailed genetic picture, but either method will confirm the presence of that extra chromosome 13 material.
So genetic testing is definitive. Are there other tests that help point towards it?
Yes, definitely. Ultrasound scans during pregnancy are crucial. They can often pick up many of the associated structural abnormalities, the heart defects, the brain issues like holoprosencephaly, the facial clefts, the polydactyly. These findings on ultrasound would raise strong suspicion.
Right, so ultrasound flags it, genetics confirms it.
Pretty much. And then once a diagnosis is suspected or confirmed, genetic counseling is absolutely vital for the parents.
Why is that so important?
Well, they need a thorough understanding of what the diagnosis means, the prognosis, the potential for recurrence in future pregnancies, especially if a translocation is involved.
Ah, yes. You mentioned testing parents for translocations.
Exactly. If the baby is found to have Patau syndrome due to an unbalanced translocation, it's recommended to test the parent's chromosomes to see if one of them carries the balanced form of that translocation. That has significant implications for future family planning.
Makes sense. And options for future pregnancies.
Yes, screening and prenatal diagnostic testing, like chorionic villus sampling, CVS, or amniocentesis, are available for future pregnancies, especially if there's a known increased risk due to a previous affected child or a parental translocation.
Okay. So diagnosis involves imaging, detailed genetic workup, and really crucial family support and counseling. Once that diagnosis is made, perhaps after birth, what does the management look like for a baby with Patau syndrome?
Management is complex and requires a real team effort, a multidisciplinary approach.
Who's typically involved?
You'd have input from genetics, neonatology, the newborn specialist, cardiology because of the heart defects, neurology for brain issues, potentially surgery, palliative care. Really, any specialist needed based on the baby's specific problems.
And what's the main goal of management?
The primary focus is on providing supportive care. It has to be tailored very individually to the baby's needs, addressing the specific health challenges they face, aiming for comfort and quality of life, however long that may be.
Is surgery ever an option?
Surgical interventions might be considered yes, but usually only for specific life-threatening conditions, like certain heart defects, perhaps. The decision is always very complex, weighing the potential benefits against the significant risks and the baby's overall poor prognosis.
Yeah,
And critically, parental wishes are paramount in these decisions.
that makes sense. What about something as basic as feeding? I imagine that can be difficult.
Yes, feeding is often a major challenge, especially with cleft lip or palate or neurological issues affecting swallowing. Esogastric tube feeding or even a gastrostomy tube directly into the stomach might be necessary to provide nutrition.
And again, decisions around that are complex.
Very. All decisions about interventions, including feeding support, need very careful, sensitive discussion involving the parents, focusing on the infant's comfort and well-being above all else.
It sounds like an incredibly difficult situation for everyone involved. Which brings us to the prognosis. What is the overall outlook for babies born with Patau syndrome?
Unfortunately, as we've touched upon, the prognosis is generally very poor. This is due to the severity of the congenital abnormalities and the multitude of potential complications.
Do we have figures on survival?
Yes, the median survival time is often quoted as being very short, perhaps around 2.5 days.
Only a few days.
Often, yes. While some infants do survive longer, maybe weeks or months, survival beyond the first year is uncommon. The rate is estimated to be somewhere between 5 and 10%.
And for those who do survive longer.
Those individuals typically face profound long-term challenges. Severe intellectual disability is expected, along with significant developmental delays, a high likelihood of seizures, and often persistent feeding difficulties.
That's a very sobering reality. You mentioned screening during pregnancy earlier. Could you just recap how Patau syndrome might be picked up before birth?
Sure. So prenatal screening options exist. As we said, ultrasound can detect suggestive structural abnormalities. Then there's combined first trimester screening.
That's the blood test and the neutral scan.
Exactly. It combines maternal age, the neutral translucency measurement on ultrasound, and levels of specific hormones in the mother's blood PPA and HCG. This combination screening is quite effective, identifying over 90% of cases of trisomy 13.
And later screening.
Second trimester screening is also possible, usually involving different blood markers. And now, non-invasive prenatal testing, NIPT, which analyzes cell-free fetal DNA in the mother's blood, is increasingly used and is highly accurate for detecting common trisomies like 13.
So there are several ways to screen.
Yes, though it's worth remembering that screening only gives a risk assessment. A definitive diagnosis requires invasive testing like CVS or amniocentesis to analyze the baby's chromosomes directly.
Right, and detection rates vary.
They do. Diagnostic tests like amnio or CVS will pick up virtually all cases if performed. Serum screening alone has lower detection rates. And sometimes, despite screening, the diagnosis isn't made until after birth based on the baby's clinical features. We also need to remember that even after a prenatal diagnosis, some families choose to continue the pregnancy, preparing for the challenges ahead.
Okay. Finally then, for babies who survive the initial period, what are the main complications they might face?
The complications really stem from the underlying condition. So you have the profound intellectual disability and developmental delays we discussed. The congenital heart defects often require ongoing cardiology care and can cause problems. Structural abnormalities in other organs can lead to issues. Feeding difficulties often persist. Breathing problems or respiratory issues can arise from structural issues or recurrent infections. Vision and hearing impairments are also common. These children often have an increased susceptibility to infections, possibly due to immune system issues. And ultimately, even for survivors, there is still a significantly shortened lifespan compared to the general population.
It really underscores the pervasive impact of that extra chromosome.
It truly does.
Okay, so to quickly recap our deep dive on Patau syndrome. It's a severe genetic condition, trisomy 13, caused by that extra chromosome. It leads to multiple significant physical and developmental problems.
Severe intellectual disability, heart defects, facial clefts, polydactyly, those are key features to recall.
Definitely. And understanding the cause, usually a random error in meiosis, the clinical features, the diagnostic approach involving genetics, and sadly, the generally poor prognosis is really crucial, especially if you are revising this topic.
Absolutely.
For more resources to help with MSRA revision, remember to check out pastthemsra.com.
And freemsra.com as well.
Great resources there. So maybe a final thought to leave our listeners with. Considering the severity, but also the variability we see, especially in mosaic cases, what are some of the key ethical considerations that arise around prenatal diagnosis and the subsequent management decisions for trisomy 13? Something to think about.
A very important and complex question indeed.
Thank you so much for joining us and sharing your expertise on this deep dive.
My pleasure.
And thank you for listening.